just say hello and welcome to everybody. Today's webinar is Behaviours of Concern, the CL Psychiatry perspective. So my name is Carlos Bello. I'm a physiotherapist of the Ambulatory Pain Management Service. I think we don't need to be as formal now, but I just want to introduce everybody here. So we have Karuna and Melissa Jordan, who I will talk about later because they're our speakers. We have Paul Beaton, we have Jeremy Smerling, we have Annie Williams, we have Vivian Prager, we've got Alison Thomason, we've got Eddie Purnell, and we've got Luisa Fernandez-Gonzalez. So this webinar is part of a series of webinars called the Pain Management Clinicians. These are designed to support doctors and allied health professionals to develop their knowledge and skills in the management of complex pain presentations. So I'd like to introduce our presenters. So Melissa Jordan, who is very well known to me, is a stage 2 psychiatry registrar undertaking her fellowship training with the Royal Australian and New Zealand College of Psychiatrists. She has recently completed her Masters of Psychiatry at Melbourne University and is currently a CL Psychiatrist team member at Eastern Health. So we also have Karuna, Taluja. I don't know if that's the right pronunciation, but that is the pronunciation I'm giving. So she's a final year psychiatry trainee that's worked at Eastern Health for 9.5 years. So she's currently pursuing her advanced training in CL Psychiatry, which is expected to complete in the coming weeks. So advanced congratulations.
Actually, it completed yesterday. As of yesterday,
really?
My training time is knocked off. Now I'm just waiting for my case results to come back and then I'm done.
Congratulations. So Karuna has worked in the PJC Subacute Pain Clinic, which is our pain clinic. She's also worked in HARP and more recently in the Functional Gut Disorder Clinic and the Perinatal Emotional Health Service. Really, thank you so much for making the time to prepare and making the time to present to us. And I will hand over to you guys.
Thank you so much, Carlos. And I think this is genuinely on the behalf of your psychiatry. I can say that. Thank you so much for giving us the opportunity to present. We have had a fantastic relationship with the pain team for years. And I can see Annie in my left corner there. In some ways, I think I can say it with confidence that we've really trained a lot of the people we have worked with to pick up the complex patients and for them to be referred to us. And in particular, I have worked with Annie in the clinic and in Vauxhall Hospital, so I can say that with 100% confidence. So it's really good to see you, Annie, after a very, very long time. In terms of the presentation today, so we're doing it in 2 parts. I am going to be doing a chat or a presentation. I like to call it a chat. It's so Zoom and social media oriented on managing challenging behaviors. And I've kind of tailored it a little bit to the pain service side of things. I'll give you an overview of that as I start. Melissa Jordan will be presenting a case that she has recently managed and seen at Vauxhall Hospital, and a lot of it may be a part of the presentation itself, but a lot of it may not be because the presentation is a bit more general to the role of CL Psychiatry with some specifics about the role that we play in chronic pain management and our role with the clinic as well. So I wouldn't waste further time, and I'll see if I can now share screen and start my presentation. Right, okay. So role of CL Psychiatry in managing challenging behaviors. The overview of my presentation is that I'm going to be talking a little bit about CL Psychiatry in general, about psychiatric assessments, managing of challenging behaviors as inpatients, and something that I thought was an idea that I always had in mind when I did the pain clinic and that I have recently tested and tried at the Functional Gastrointestinal Disorder Clinic and Integrative Management, and I'll talk to it when I do the presentation. Now, I'm sure you know about us, but I just thought I'll talk a little bit to it. We take referrals from the inpatient settings. In the outpatient clinic, as you said, Carlos, we if there was no COVID, we were doing a fortnightly face-to-face clinic at the Peter James Center, which is currently run by Louisa. And we do the weekly MDTM meetings, which are on Friday mornings, attended by Louisa, Catherine, members of the APMS, and the Drug and Alcohol Services. I think it's a fantastic forum to raise complex clients. So we have a team which is based at Boxall Hospital, Maroondah Hospital, and Anglis. We've got medical and nursing staff. The kind of things that we have normally seen with a chronic pain, and I may not have covered all of them, but the common presentations in terms of psychiatric comorbidities include depression, anxiety, borderline personality disorder, post-traumatic stress disorder, and psychological distress in general. What does it look like in a patient? So it can manifest as challenging behavior, which is what we're going to talk about, poor engagement, frequent presentation to hospitals, prolonged stay in the hospitals, and difficulties with discharge. My reason to kind of mention those areas in particular is because I think CL Psychiatry has played a key role in trying to manage at least the last three aspects of those challenging behaviors. And I can say it with a certain confidence that at least in the last couple of years, we've had patients a group or a cohort of patients who've actually stayed for more than 6 months and have had involvement from various teams, and it has been quite challenging. So I just thought I'll talk to it as well a little bit. In regards to the inpatient referrals, so we obviously do psychiatric assessments. We provide recommendations on medications, behavior management, and I'm going to give a practical example to it towards the end of it in terms of a template itself. Providing education to the home team, liaison with the multidisciplinary team members, capacity building for nursing and allied health staff for better management of complex patients. I think that is something which is extremely important when it comes to management of these clients. And I know pre-COVID, there had been more education sessions pertaining to that in particular. Hopefully we can get back to it in the future. Regards to the outpatient clinics, again, as I said, fortnightly, attended by the psychiatry registrar. We do assessments. We work very closely with the pain team and the drug and alcohol services. And again, similar stuff such as medication recommendations and advice on management. Now, my reason to talk about this particular slide was I think there is not a very clear understanding of the kind of things that we do in terms of a psychiatric assessment. Kind of things that you would know probably about psychiatric assessments would be that our assessments are really long. We can take up to an hour or an hour and a half to complete our assessments. And I thought it'll be really good to focus on that so that it gives an idea of what we're really trying to understand and what we're really trying to explore. So as I said, our assessments are comprehensive. What we're really trying to see is we're really exploring the patient's life. We follow an approach with lots of open-ended questions, and there's a lot of focus on trying to understand how pain is really impacting their life. We ask questions on their childhood, their relationships, the overall trajectory of events in their life, their response to stressors, coping mechanisms, personality structure, etc. Now, this will become a little bit more clear when I come to what is it that we're trying to achieve, but that's the depth of it as to what we go in when we do an assessment, especially on patients with chronic pain. We attempt, if we can, and if we get the consent of the patient, to get collateral information, because I think that's really important, especially for the ones who have suffered with chronic pain, because their carers can really give us a sense of how it is impacting the quality of life, what has been tried, what is their concern. More often than not, they're on the verge of a burnout themselves. So I think it's really important to get that sense as well. It helps us understand the needs of the patients, what their expectations are, and setting goals of care with them. Now, all of this that I said requires time and it requires a good rapport. And it's not always possible in an inpatient setting, especially at times when there is a code gray call and the patient is really aggressive and quite unsettled. So we're really unable to do all that. And the middle part of the presentation focuses on those times when we can't really do a comprehensive assessment and the kind of things we can do at that stage. This I thought was quite important to talk about, and in no way stigmatizing the presentations that we do see, but more often than not, I think the comprehensive assessments that we do are trying to basically rule out what is going on other than an organic cause contributing to the pain. Care eliciting behavior, abnormal illness behavior, sick role, if there are any secondary gains or malingering. And I know that all of these are actually quite confronting. They're actually quite a sensitive stance that we take when we are exploring a patient's presentation, and often can be really difficult to present back to the patient. And henceforth, what we really would, I think the next part of it talks about what our approach is and how we can really try and talk to the patient if any of those are a part of their presentation. What we often find useful is the approach that we use. So we obviously try to use a very collaborative approach. Psychiatry has got a huge focus into what we call the collaborative recovery-oriented model. This has been there for the last many years, but the last 5 or 6 years has really seen a focus on this. And a big part of it is the language that we use. The language that we're using with the patients has to be very recovery-oriented. Obviously, providing the reassurance to the patient, providing education. We tend to talk a lot about mind-body dualism, and I think this is where the role of the history that we have taken, the formulation that we present, ties on really well, and we can explain the patients how the pain that they are experiencing is in fact a manifestation of their psychological distress. Validation, which is extremely important. We often hear when we see this patient cohort that they kind of say it's not all in my head. And I think that's where to be very important that you're not reactive, but at the same time, being quite realistic that pain likely is constant and will be a part of your life. And that's something that you will experience every day if I was to ask you that question. And I think henceforth tying the focus into the fact that what's really important is how can we improve your coping strategies and what are the short-term and the long-term goals of care. So being quite realistic about that. Now, the key component and something that we find which is really, really useful when we engage with our patients and we have done an assessment and we've kind of used a recovery-oriented language and we've done everything, the aim is to be able to provide them with what we call as a formulation. I don't know if a lot of you are aware, but it's not the diagnosis of the patient, and it's very different from that. So I'll talk to it a little bit. What it essentially does is that when we've actually taken a comprehensive history, we're able to kind of tie it all together, summarize things to the patient, and trying to explain things in terms of why they are the way they are and why now. So this is basically trying to tie their symptomatology, connecting their physical health, connecting the trajectory of events that they have experienced in their life or the stressors and why we're actually seeing them and what is it that will be useful for them. There are lots of components to it, and my future slides talk about that. As I said, it's completely different from a diagnosis. It's a very integral part of a psychiatric review. It actually gives you a very good understanding about the complexities of the patients because you're really looking at their life from the time they're born until the time that you have seen them. It is essentially based on what we call the biopsychosocial model, and it talks about the interplay between the biological, the psychological, and the social factors. We often talk a lot about with our patients about the medical model versus the biopsychosocial model. And I think chronic pain is a perfect example of what fits really well with an explanation from a biopsychosocial perspective. It's obviously based on the history that they have provided, but I think the one thing that psychiatry often uses for this is a hypothesis. Very often I tell my patients that you've given me all this detailed history. I'm sure there is stuff that you have forgotten, and I'm sure there's stuff that I haven't actually not asked you. But with whatever you have told me, I'm able to generate a certain hypothesis and talk to your diagnosis and how we can really help you. This is a formulation matrix that we often use. And if you see on that, you've got, so there's obviously the biological, psychological, and the social factors. And on this side, you would see, we often call it the four. It actually is 5 Ps, but we've got the predisposing factors, the precipitating factors, perpetuating factors, and the protective factors. The last P is a prognosis or the prognostic factors. What we're essentially trying to see is what are the kind of things that, in a biological perspective, predispose a patient to a mental illness, family history, birth trauma, them using medications, response to medications in the past, which tells us there is a biological propensity to them having a mental illness, drugs and alcohol, and pain. That's one of the factors which will predispose them to a mental illness. So those are the, coming back to it, so that's biological, psychological, social factors, and predisposing, precipitating, perpetuating, protective, and the last one is prognostic. Now, biological factors is essentially if they do have a family history of a mental illness, tells us that they will be predisposed to getting a mental illness. If they have used antidepressants in the past and had a partial response, also tells us there is a biological component to a mental illness. History of drug and alcohol use, and if you see, pain actually is one of the biological factors as well that predisposes them to having a mental illness. The psychological factors, personality. Now, this is something which we may or may not be able to get a gauge of in a 1.5 hour assessment, but what we're essentially trying to see is their personality structure, which is how have they really dealt with things over the years. Modeling, what is the kind of parenting they have seen? What is it that they have seen? If the father uses alcohol and this is what they have seen as a parenting template, not likely, not 100%, but there is a chance that likely they would use the same kind of a modeling when they are managing with stressors. Psychiatry talks a lot about defenses, mature and immature defenses. What is it that they use? And I think this is something which chronic pain patients that I can definitely relate to in a code gray scenario, when there's a lot of projection and they project all of their anxiety on the clinicians who are in the room, and you end up feeling almost powerless and almost feeling really sorry for the patient and blaming yourself that you could not do enough. And I think reflecting back and thinking about what's really going on in that process. Coping strategies, again, adaptive or maladaptive. What we often see is in patients who've been frequently presenting to hospitals, we see things like using medications as a means to adapt, or things like using alcohol or self-harm. Things of those natures tell us that their coping mechanisms are not as adaptive and can be worked on. Self-esteem. Now that ties really well with the trauma. Somebody who has been subjected to physical, sexual, mental, emotional trauma of any kind, their sense of self and their self-esteem would be significantly impacted. And what it does is that it makes them feel quite sensitive to any kind of rejection. They feel easily abandoned. And what we see and what transpires into a hospital setting is when they see authority figures and when the demands are not met, their sense of self has been so fragile that they end up feeling quite abandoned and rejected by the clinicians in that setting. Social factors. In terms of precipitating factors, what we're really trying to get a sense of is what has really happened in the last few weeks or the last couple of months in these three domains, biological, psychological, and social domains, that would have contributed to the current presentation. Stressors of any kind, loss, grief, relationships, and henceforth our assessments focus a lot on their significant relationships, how they actually managed the breakdowns in those relationships, and how was the way that they really coped with it. So what I'm essentially, I think the crux and the gist to it is that any psychiatric assessment that we do, that 1.5 hours is trying to get a sense of all of those things. And once we've done that, we actually present it back to the patient in a recovery-oriented language and in a collaborative fashion, asking them what their thoughts are about it. Very often they agree with it, but there are times when they do not agree with it. And I think that is something which needs to be factored in as well. The one thing which is not mentioned here, and is the last P, is a prognostic factor. We basically look at the kind of things that will be helpful for them, whether it's long-term psychological therapy, whether there is a role of medication, is there a role of rehab, is there a role of the three together that is going to help them, is there a role of MDT liaison. So all of that is something which will guide their prognosis. The one thing that I must mention here, and I haven't spoken about, is the protective factors. What we're really trying to see is that, is the patient engaging with us? If they are engaging with us, if they do display some insight, if they do adhere to the medication recommendations, that does tell us that there is they will do well given the right supports, which will guide their prognosis. I think I'll move on from this. This is just an example that I was trying to put in about this a patient who had all this happen in her life, and it was really easy to kind of then understand why was she the way she was when she got presented to us. So if you see here, maternal aunts abused alcohol, so there's a genetic history there. She herself abused alcohol. She had a very anxious attachment as a child. She saw her father use alcohol. Coping strategies with alcohol. So all of this really gives us an understanding of how we can help her and what has really happened previously in her life. As I said, I've already spoken about this, that those are the components of the formulation itself. And what it really does is helping us understand the patient's thoughts, their feelings, and their behaviors. The one thing that I wanted to talk about, because I was trying to say that a formulation is different from a diagnosis, and I thought it's really important to mention because this is what we see quite commonly when it comes to our referrals. Most of the patients that have been referred to us, based on the referral, it says that they have a known diagnosis of a depression, anxiety, or a PTSD. When we actually review them, not all of them actually meet the DSM-5 criteria at the time of the review for any of these. And what we actually see very commonly is an adjustment disorder with a depressed mood. What we see is a mood and affect dysregulation, which can be best explained by cluster B or borderline personality traits, or a substance abuse or substance use disorder, abnormal illness behavior, and psychological distress. My reason to put this slide in place is just to be kind of aware that when we do see chronic pain patients and we see that they do have that diagnosis, it is not necessary that at the time when they have been referred, they have that as a diagnosis. And I think a comprehensive psychiatric assessment will help us understand what's really going on for them, and then obviously provide recommendations based on that. The kind of barriers that we see why people do not want to engage with psychiatry, and this is inpatient and outpatient, when patients miss appointments in the Peter James Center, I would often end up talking to Andrew about this in particular. And I thought that this is something which is quite important to discuss. Stigma. It's still a big part of not engaging with psychiatry. There's almost a sense that maybe the pain doctor felt that it's all in my head and they referred me to psychiatry. Pain seen as a standalone medical condition, and there's a lot of focus on medical management. I've often had, and I can say this again with a certain confidence, in most of my pain, the referrals that I got from the outpatient clinic, the patients often use a lot of medical jargons. There's a lot of use of medication names that they throw upon you, and you almost feel that this is being seen from a very, very skewed perspective. And obviously personality vulnerabilities that affects their engagement and with psychiatry. Now, coming on to this part of the presentation, which I think is important because not every time patients engage with us. And I thought that this is more relevant to a scenario in an inpatient or outpatient setting when the behavior is quite challenging. The term that we use is challenging behavior to describe a patient's behavior, which could be of any intensity or frequency, causing a physical or a psychological safety to the patient or anybody else around them at the time. It can actually affect the quality of care of the patient and can also challenge the team's function at the time. What can it look like? Wandering, agitation, aggression, refusing treatment, verbal abuse, screaming, threats, intimidation, demanding behavior, self-harm threats or actual self-harm, substance use, demanding medications, in particular pain relief, intrusive behavior, manipulative behavior, and obviously if they're unwell and they're psychotic, so they could be paranoid or actively responding to hallucinations. What does it really do? So it ends up making the staff, anybody who's involved in their care, feel quite helpless and powerless. You feel quite angry and at times quite frustrated with what is really going on. There is a likelihood that you actually develop a punitive attitude towards the patient, and there's almost this expressed negativity towards the patient. It becomes more and more apparent as you keep having those encounters with the patient. And what it often does is that it can lead to a fragmentation within the team. And there is a sense that, okay, so this is the medical management, the nurse who's looking after her, the physios who came to check in on them. And there's almost the subdivided systems that get formed. In psychiatry, we often talk about it in terms that if in handover we are discussing a patient for more than 15 or 20 minutes, we actually try to reflect upon it and see what is it that's going on. And clearly this patient has generated a certain amount of anxiety in all the systems involved, the professionals involved, and henceforth we are really discussing them for all that time, which is reflective of the complexity that they present with. The interventions can become quite reactive rather than being dynamic and proactive. I think just to when you think about this, I think it's probably very difficult to put yourself a step back at the time, especially in a code gray situation. And henceforth, I think ongoing education and discussions and talks like that would be really useful, because on reflection, you realize you probably were being more reactive based on how the patient made you feel when they were projecting all their anxiety on you. When it comes to the management, obviously ensuring staff and patient safety, Consistency of care, extremely important. I'll talk more to it as we kind of proceed in the presentation. Developing an understanding of the behaviors and planning the interventions, which is again something which is a part of the management plan, and I'll come to that as well later on. Providing support to the staff, debriefing, education, and training. Extremely, extremely important, especially for staff who have not worked within a mental health setting and are working with these complex clients. The education, support, and the debriefing plays an extremely important role to prevent the staff burnout and looking after their emotional needs as well. What could be the precipitating factors? Could be physiological, environmental, psychological. Pain being one of the physiological factors, urinary retention. Environmental could be something as minor as a change of a room or being in a cluttered space, being in a room where there are other patients who are quite loud. Psychological, obviously pertaining to the psychological distress that they are experiencing, either as being in the hospital or something else that has happened prior to them coming in. The kind of things that we really have to remember are a non-blaming thinking. The problem is the problem and not the person. Labeling the person is obviously not quite constructive to the management of the patient. Limit setting, extremely, extremely important. Telling the patient, and I think what we've often noticed is that at times when we have patients with chronic pain, and as I said, that they are aggressive for whatever reason, and they're projecting their anxiety on you, their language that they use and the body language that they display can be quite intimidating, and telling them that actually that is unacceptable. I can't remember the amount of reviews that I've done with the pain team, especially with Annie and Galahad. I remember a particular review. We had a very difficult, complex client in Vauxhall, and really using those terms, and you can almost see a change in reactivity in the patient, almost not believing that you've actually called them out on that. Consistency and limit setting, very, very important. And to be able to communicate to them their expectations that they have and what can you really do for them, and making them feel independent about what's really going to happen, providing them with choices, and all of that will come as I go down the presentation. Very important, being aware of splits. Patients who've stayed in the hospital for very long have obviously felt that whatever they needed and whatever they wanted to achieve has not been achieved. With personality vulnerabilities in particular, and the use of manipulative behaviors, one has to be extremely important of splits within the team. Common examples, the nurse I spoke to yesterday was lovely, or the physio who came in today was fantastic, and I only speak to doctors. Being very mindful that when they are giving those kind of comments, they're clearly causing a split within the team. The term that we use for patients with personality vulnerabilities is idolization and denigration. They'll idolize you one day and they denigrate you the other day, and you could be in their good books or their bad books within a matter of a few seconds or minutes. So being very, very aware of those splits. So when it comes to key contributors, they're fearful, and perhaps that's why they're aggressive. They're frustrated, so they're aggressive, and they probably feel as powerless as you do, and so they're aggressive. What needs to be done? Being very, very aware that you are at a safe distance from them when you're in a room, and this is particular for the inpatient settings. You don't trap them, but then you are making sure that you're not trapped in a situation like that as well. Self, and I think this is really important when it comes to a code gray situation or acute aggression in particular, the verbal and the non-verbal body language and cues that you are demonstrating, and the patient is picking on to that. Non-threatening body position, eye contact, hands down, just being quite attentive to them, trying to be as simple in whatever that you're trying to talk, avoid any medical jargons, tell them that you understand that they are feeling quite upset and they are quite aggressive. Speak low, speak slow, keeping the request very simple, very direct, obviously demonstrating the respect and trying to understand what is it that they are really feeling, but at the same time, making sure that you set limits. If they are aggressive towards you, making sure that you tell them that that's not okay and that's not acceptable, and for them to actually talk to you about how they really feel. May not happen all the time, but those are the kind of things that we really need to watch out for. So again, this is kind of tying back to what I said earlier. What could be really happening for them? Are they in significant amount of pain? Are they worried that they're going to be discharged? Are they actually, is it just that they need a glass of water? Do they just need a cab voucher? What is really going on for them, and getting to the root cause of that to be able to really help and support them. When it comes to managing the behavior, so there's one situation which I described earlier, which is a very acute situation where you need to call a code gray. When you have called the code gray, the patient is more settled and the patient is still in the hospital. What you really need to think about is long-term management, and that has to be a multidisciplinary team approach. All the members of that team, all the members who've been involved in looking after that patient, including the home team, pain team, allied health, nursing staff, the NUM, CL Psychiatry, if there is a special carer, everybody needs to be a part of that MDT approach. If there are any family supports or carers, definitely liaising with them. And whatever that is planned in the MDT is obviously guided by the patient presentation and the goals of care they have. Pre-COVID, I know that we've had some complex patients, and we used to have times when we met as a MDT on a Thursday for some patients or on a Wednesday afternoon for other patients. And the idea was to really get a sense of what's really happening now. Each member of the team has their delineated responsibilities, what is really being achieved, and what is the next goal. Once the meeting has happened, then providing the patient with an update or a summary of what was decided in the meeting so that they are also on the same page. And that is what the collaborative recovery focused approach and managing chronic pain is all about, making sure that the patient is aware and there's a consistency in the plan that is being followed. In the management strategy, and again, this will come when I talk about the template as well, but I'll briefly mention here as well. Possible aims could be pain management. Are there any rehab goals? Is discharge a goal? Who's doing what? Ensuring that the strategies that are in place are not really compromising staff well-being at any point, and making a very clear plan as to how these interventions will be implemented. And I know that I keep harping upon this, but this is actually a key to it being consistent. Assuming one down position, which I'm sure we all do anyways, I think this part of it, which I think is a key concept in providing a sense of control, is extremely important. And how that really happens is that when you are providing them a summary of what has been discussed in the multidisciplinary meeting, you're working with them on what they think are goals of care. You get a sense from them about how they think they can achieve it. If they're not really clear about it, then providing them with choices and really letting them make the decision. As simple as this sounds, it makes a huge difference because you're really involving the patient, but also you're actually putting the responsibility on the patient to be able to manage their care. And this way, it makes them feel more involved. And I think it can, in some ways, if they are psychologically minded, they can actually reflect upon it later on as well, that you did give them a choice and things did not really work out. Some useful things, again, there are no blanket rules. Each patient that we have a management plan for is a different management plan because their needs, their goals of care are different. Again, some things to remember, which I've said earlier as well, do not take their comments or their behaviors personally. I think this is extremely important because of the way they project their anxiety on you when you're in the room. And try to not make any promises to the patients. And this is, again, coming from the fact that when you talk about personality vulnerabilities, when you talk about their childhood, when you talk about the trajectory of events they have seen, they've probably come across people that they trusted because they were promised something, those promises were not fulfilled, and that's how they have developed the trust issues. And likely if you make a promise, they will, and if it is not fulfilled, not because of any of your faults, they are likely to feel quite abandoned, rejected, and that's going to impact on their engagement in their management with you. Now, this is a very general template that is there in EMR, Behavior Management Plan. I don't like it. I think it's really, really crowded. And I think it's really good to kind of have as a document because I know EMR had these updates and it can be there. I thought I'm going to share a management plan that I had written up for a patient last year. And I'm just now going to try and see how do I get out of this to be able to do that. This is a management plan that I had written, but this was, I must mention that this was an extremely complex patient. And this management plan was actually read by the medical legal at Eastern Health because of a couple of things that were actually written in the plan itself. This was a patient in oncology who had pain, had chronic pain issues. There was drug and alcohol use, and there was obviously difficult behavior given their personality structure. So if I've highlighted a few things that I had actually written in the management plan that I thought I'm going to share with the team. So if you read here, I've kind of written the purpose of this plan is for XY to get an understanding of his rights and responsibilities as a patient and to set out minimum standards of behavior expected of him while he remains in the hospital. He has a right to receive quality health care, participate in decision-making about his patient, however, be treated with courtesy as well. If his behavior causes an unacceptable risk to staff or members or to the hospital can actually refuse to provide care to him. And now, because of this particular line, this plan was reviewed by the medical legal at Eastern Health, because that's the decision that we had come on to. He does have the right to refuse treatment, and this was a discussion that we had with the patient, and we clearly documented that as well. He has a responsibility to treat hospital staff members with courtesy, avoid being aggressive, abusive, or threatening towards any staff members in relation to his treatment, or treat hospital property with respect. The hospital is required to provide a safe environment for its staff. This includes providing a workplace that is free from aggression, abuse, and intimidation. So this was making it very clear to the patient XY himself that this is what we are looking for, so that he knew what we were expecting. Making it even more clear in dot points, so we wrote it this way, that he's required to cooperate, treat hospital staff with courtesy, avoid acting in aggressive, treat with respect. He was on oxygen, so making it very clear that he knows that he can't smoke when he's on oxygen. Pain relief as per schedule details, and if agitation develops due to pain, use of psychotropics such as olanzapine. Now, all of this is again kind of a repetition of everything that I've said earlier, but it's essentially trying to make it clear that this is what is going to be a part of his treatment, that he needs to cooperate, that he cannot be aggressive. If he does become aggressive, he needs to leave the premises. If he chooses to leave the ward or discharges against medical advice, he comes back, that he's at a risk of potentially having worsening of pain, shortness of breath, or death, and the fact that he'll have to come via the emergency department. In this particular scenario, what was happening was that the patient would go away from the ward, and he would be missing in action for hours and hours and then come back. He did have the hospital wheelchair. He was on the oxygen cylinder, so there was a lot of risk that the hospital was holding, because he was with hospital property when he would be out from Vauxhall Hospital and go all the way to Blackburn. So all of this was obviously taking into consideration this particular patient's needs and what really had to be done. It was made very clear to XY that these are the members of his team: oncology, nursing, APS, consultation liaison, psychiatry, and addiction medicine, and that this plan was not the responsibility of the one person, but came from the multidisciplinary team, also reviewed by the hospital management. And that way, XY did not blame any particular person about why this plan was put in place, and that we all came across with a consistent message as a team, and that any change would be reviewed by all of the members of this team. This plan was signed by him and by the hospital management, and a copy of it was given to him in his room. The other thing which was accompanied with this management plan was a very clear table of the medications that he was on, in particular the pain relief, what time he would be provided those medications, so that there was no, there was no confusion and communication gaps around that. There was a lot of benzos that he was prescribed on in particular, and there was quite a confusion with that as well. So we made things very clear. Visual aids, extremely, extremely important. Sorry, coming back to the presentation, I'll stop share from here and I'll go back to the presentation again. Yeah. That's the example that I gave. In terms of supports, obviously, colleagues from CL Psychiatry team are always available. We give a lot of value. We put a lot of value and weight on the role of debriefing, the role of supervision, the role of training and education when it comes to managing patients with the behaviors that I have just described. Now, this is something that I thought I'm going to talk about, which is an integrative approach. And what I mean by that is joint reviews. I have recently done my scholarly project on that, and it's been commenced in the last 3 months in the Functional Gastrointestinal Disorder Clinic. What we do with this approach is that I see the patients on my own, and then we have a joint review with the gastro team and with dietetics. And so we're seeing the patient at the same time. Why I thought that this was really useful and why we think it will really work is that it kind of improves the acceptability to the role of psychiatry in general for the patients who've had chronic pain concerns. It addresses stigma because there is a component that we have the medical doctor and the psychiatry doctor and everybody in the same room. They feel very validated about their concerns being taken seriously. It's much easier to provide an education and promote the mind-body dualism, promotes holistic management. We can make the approach quite recovery focused when we're doing it as a team. And the most important, which is what I've spoken about a few other times today, is consistent message to the patient for better management of complex clients. And as I said, we've tried it in the FGID and we thought it was quite useful. For anything, feel free to contact us, CL Psychiatry Nurse or the CL Psych Reg via the switch. If we are not able to review the patient as a primary consult, we do a lot of secondary consults as well. And I think the MDT meetings that Catherine and Louisa attend, they're fantastic. It's a great platform to discuss these patients. That's all from my end. Thank you.
Okie dokes. We have two options. So we have the option of going to Melissa's case presentation, or we can record Melissa's case presentation at a later date and then open it up for questions. It really depends on Melissa. Are you okay with that?
I'm happy with either. I think time for questions is really important, and I can certainly record this. My case presentation covers a lot of what Karuna had to say anyway. It just contextualizes it with an example of a person.
Yeah, beautiful.
Sorry, with the computer issue that I had today, I can't believe it got delayed. I'm really sorry.
Beautiful.
That's okay.
Thank you. Appreciate it.
I don't mind. I'm more than happy to record it with you at a later date, Carlos, and leave the rest of the time for questions if that's what people would prefer.
Thank you. I think we probably have to, I think there's a lot of questions, and thanks, Catherine, for jumping in. What I might do is I might just what I might say is that maybe Vivian, do you want to start? And then I think that Jeremy has questions, Paul has questions, and then we can see how we go with time for there.
Plus, I've tried to answer them in the chat as well, but yeah, absolutely.
Thanks, Catherine. Thank you.
I think one question that I have, and I guess probably just to bring the background in, I mean, some people know that I'm also GP, so I think from my GP background, I had a lot of chronic pain patients, obviously, and also I think patients with complex trauma, or what some people prefer to call borderline. So I think I'm, that probably more from that background, quite familiar with some of the behaviours, and obviously we see a lot of trauma patients in our addiction clinic as well. And obviously doing the OTPAC clinic and all of that. So one of the questions that I ever had, and that's almost probably thinking like, sometimes when someone's got chronic pain and we feel they benefit from a psychiatry, said there's a big stigma around that. And I actually wondered if you have got maybe like a good phrase that someone can use for
absolutely
actually bring the option of that, because as a clinician we sometimes know what's going on, but
absolutely
probably just to make palatable to the patient.
Look, that's a very valid question. I think it's a fantastic question. The one approach that I've always used in the last couple of years in particular and has worked really well, and this is how I have provided a diagnosis of a borderline personality disorder, and integrating the complex trauma component to it is I tell them the story of DSM, DSM, the criteria for classification, and how in 2013 there was, we had our new criteria DSM-5 release, and how there was a big party, Australian representative party, to actually change the name of borderline personality disorder to a complex trauma disorder. There's a beautiful talk by Jayashree Kulkarni on YouTube, and I always tell them that link. I'll tell them to open their phone and check that link. What it actually does is, and what the kind of things that I tell them is that this talk focuses on the fact that how borderline personality disorder leaves them with this stigma and this doubt when they leave the psychiatric assessment. Do I have a personality? Do I not have a personality? And they almost feel judged about it. So Jayashree tried to say that change this term and make it complex trauma disorder, but she was removed from the party altogether because there was a big debate between Americans and Australians about the use of the word trauma only to people in war. So that could not be used. But then she actually advocates and promotes that amongst clinicians, we can actually use the term complex trauma disorder, because what it does is that it validates the trauma for the patient. And the problem is that when they come into ED and you see the diagnosis of a borderline personality disorder, there's almost this reactivity, this is borderline, and you completely forget about the trauma. And I think this talk and listening to the talk by Jayashree, patients actually feel quite, that's what I've noticed in a couple of times, that they feel quite validated with the use of the word complex trauma disorder in comparison to the borderline personality disorder. But giving them this context and this whole story about it has been quite useful. Does that help?
Yes, that's actually very helpful. However, my question probably was actually very different. I mean, like, so if someone comes to you with a chronic pain problem, you think there's an underlying whole psychological convolute around it. How do you motivate a patient to actually see a psychiatrist?
Look, I think when you have established that they do have a history of trauma, trying to kind of understand and trying to explain it from the perspective that there is a known history of a trauma, likelihood is that they have already burnt their emotional reserves and their resources to really deal with what's happening in their life. Pain being one of them. If you need a certain amount of emotional resilience to deal with the physical pain that you experienced, and it is quite compromising if you've had a history of trauma because you've burnt that emotional reserve. So I kind of feel when I use that language that what psychiatry assessment would do is that we'll try and identify what are the reserves we can replenish, given that you've burnt out the reserves based on the fact that you were already in so much pain. Does that help?
Like a nice phrase to use, like to build, and it's like
that's right,
recovery language.
That's correct. Yes. And I think that when you use that language, they do identify, and I think they feel that, I do have reserves, I have demonstrated resilience, it's clearly burning out, and that's what psychiatry will help me with to rebuild those.
Yeah. Thank you.
Thanks.
Paul, do you want to ask a question?
Yeah, thanks, Karuna. That was great and really interesting. And I guess maybe you kind of answered one of my questions or a comment that I was going to make with your previous answer. But for me, there's a couple of tensions that are kind of just always there. And one is this trying not to label people, but then also getting the benefit of diagnosis. And so there's kind of that tension there, and how do we negotiate that? But I think you might have answered that with the last question, with the last response. The other is just dealing with the complexity of these clients. I feel like there's a tension to, yes, provide consistency, but also I'm aware of like the importance of doing what works. And I wonder sometimes whether for these really complex patients, we need a unique and kind of quite special approach that then may be labour intensive. And so we are kind of directing more resources to certain people that we think are so complex, nothing else is going to work. So it's just, I don't know if you have any comments about that and how we manage that.
I think with these patients, there's obviously the background work, and there is obviously the work that you're doing on front. Like, on front, maybe you're probably doing something that they feel is very minimal, but in the background, if there is a backup, that you do have a multidisciplinary team which involves all the relevant members so that you can get strategies to deal with it better, which the patient doesn't really know, and it can kind of support you and your self-care that you don't get burnt out as well. And at the same time, the patient feels that they're making the most of it if they don't want to be involved in the multidisciplinary, approach kind of a setup. So I know that the MDTMs on Friday focuses a lot on that. Like, you're discussing the complex clients. There are some who come to psychiatry. There are others who don't. And I think in those, the ones who are not turning up, I think the background work for them would be really important and relevant. Does that answer it? Sorry.
Yeah, look, I don't think, yes, it does. And also, I don't think that question's answerable to a certain extent.
Okay.
I think it's
we need a very unique model of care for these patients, isn't it? Look, in psychiatry, we do have a certain team which, we do have identify the complex clients, which are discussed maybe once a month, and there is a particular psychiatrist within the mental health program. I wonder if there is a setup like that within the pain service, integrating with drug and alcohol and psychiatry. So, yeah.
Yeah, look, I just realised that sort of within my own head, at least, there's kind of this we're kind of damned if we do and damned if we don't. So if we kind of, and often we hear the stories that these people have been handballed between one service and another service.
That's correct. That is correct.
They're not attending, whatever. But then ultimately that leads to problems, right? It leads to difficult, challenging behaviours. And so we need to find something that works for these people. Is our service the one that can do this? And is there any one that can do it? Probably not. That is correct.
Yes.
So then we're stuck with that issue of, okay, to do the multi-disc stuff takes a load of energy and effort.
And resources as well, absolutely.
And resources, which if we had directed those resources to the people that are less complex, our stats would look so much better and we would get great results.
It does beg that question, Paul, and I know that it's very difficult to answer. So I do agree. I think it's a very interesting observation that you've discussed. Yeah.
Thanks for that.
But just to remember, there's other resources as well. So we're not the be all and end all. There's Spectrum. There's loads of other external resources that people coming to Eastern Health could make use of concurrently with our services. So.
Yeah, thanks. Yeah, completely didn't realize. Thanks, Catherine. Sorry.
Can I ask a question? So I wanted to hear more about joint assessments. Because there's people that like for managers, for example, it's a lot of use of time, and if the patient cancels, that's a lot of EFT that is that's caught in for them that is not used. And then also the benefits of it. I'm just I probably only got like one position on that, and I'm wondering if you can sort of tell me more about like what you feel is like the benefits of it, and are there patients that are particularly good for joint assessments, and there are other patients that are particularly good for like a barrage of single discipline. How do you determine that, and then also how do you make the most out of a joint assessment?
Look, I think I'll tell you the template that we use in gastro. I think that'll probably give you an idea. So what we do is that when we have our MDT meetings, the gastroenterology team, gastroenterologists, they're able to actually tell me that these are the patients who we've done everything. Nothing is working for them, Karuna. They need to be seen by you. And I see them. And the sense that I get is that gastro's obviously done everything. They're actually not feeling that anything has been done. There's a communication gap which is happening here. And what we end up doing is that we book in a joint review where gastro, dietetics, and us go in. Now, the trouble is a lot of patients refuse to do it. And I think this is where gastro has been quite good in actually saying you will only be allowed to be booked in the FGD clinic if you attend a joint review. So they're being quite clear to the patients who they feel are quite complex to say that any FGD appointment that you want to come into Boxall will be a joint review with Karuna and the dietitian. The kind of benefits that we have actually observed is that in the room, because these patients are quite complex and often personality vulnerabilities manifest in various ways when it comes to either not being very clear about what management was recommended, either not following through the management because of whatever reasons, it becomes quite clear in a joint review what is really the gap and what's going on. The other thing, and this is, I can probably talk to it a little bit because I did my scholarly project on that recently. And the kind of things that the patients kind of talked about was that they felt quite validated because they felt that they were taken seriously and there were 3 people in the room trying to address it from a multidisc perspective. I feel that a lot of patients take psychiatry as a part of their treatment when we are in a joint review. Like for the ones who did not want to engage with me separately, were happy to engage with me when I saw them with Sanjay in a joint review because they thought that, oh, she's coming in to see me with a gastroenterology doctor. So this is probably a part of medicine, which is sad to say, but I thought that it really improved their acceptance to psychiatry getting involved. When you talk about mind-body dualism, I almost feel that the ones when I'm doing single reviews for patients who do not have a good psychological mindedness, I feel that I'm talking, but it's not really making sense. And in practicality, a joint review really promotes that discussion about mind-body dualism and the integrative approach, and catching up with the patient as in that multi-disc setup once a month gives you a sense of what kind of outcomes you have actually achieved, what has become better. More often than not, what we've seen is that they didn't really have an improvement in the gastro symptoms. What did become better was their ability to cope with their gastro symptoms or their quality of life, because we had a discussion in the formulation about their relationships, what has been helpful and what hasn't. So I thought those were the kind of things which were really, really helpful in this perspective. And I kind of feel that chronic pain patients kind of sit within the same cohort profile, if that makes sense. And I think I remember JK attended a couple of reviews with me when I was doing the PJC clinic, and he used to come into the assessments that I did, and we never really formalized a joint review concept in the chronic pain setting, but just something to think about.
Thank you. That's great. I don't know where I'm. Yeah. Just a random question. I would love to grab some resources about joint assessment from you if you have them.
Look, I have them more specific for gastro and psychiatry, integrative medicine. So I can probably provide you, because I've done my project, so I can probably send you some articles your way, so you can have a read of it. But it's more relevant to gastro and psychiatry doing integrative approach management.
Yeah. Awesome. Thank you. Any other questions, guys? Annie, you look like you want to ask a question. Maybe
what? No.
No. Okay, cool. It's just that your posture was like, oh, she's wanting to.
No, I was actually typing that I have to leave and saying thank you.
No problem.
But actually, Karuna, I will ask a question. Can I have a copy of that generic plan for you, please? Because I've just come off a meeting before this one for a very similar situation, and we need to formulate such a precise plan.
We've got a couple of them, Annie. Is CL Psychiatry involved in the patient you're
referring to?
Okay.
Yeah. Louisa was in the meeting.
Okay. Okay.
So it's just actually the precise details.
I'm happy to send it to Louisa. Yep, not a problem.
Yeah, thank you very much. That's fantastic.
No.
Good to see you.
Good to see you too. Okay. Thanks, Annie.
See you later. Thanks, Carla.
Yeah.
Thank you, Go. Thank you.
Bye.
So I reckon what we might do is we might wrap up. We have Melissa's case presentation to do, and I'm thinking that probably I'll look at the transcript of this, because there's a lot of questions, and maybe what Melissa might agree to is that we might do a bit of a shortened one where we do a case presentation, but we have more time for questions, because it looks like there's a lot of questions. Would that be okay? I might email Melissa, Karuna. I might email you guys to arrange something like that, which would be like a little bit shorter. And I'm not sure how we're looking for the rest of the year, but we'll make a time.
Absolutely, not a problem.
Yeah. Otherwise, we're going to be recording this. So we're recording this, and we're going to have this for people available. And then what we might do is we might also invite other people to the next part of it. So thank you, guys. Thank you for your time. Thank you for your knowledge, and thank you for your contribution to our team.
Thank you, Carlos. Thank you very much, everyone.
And it seems like we're going to be having a part 2.
Sorry about that. I feel terrible.
No, it's just because we've been really wanting to have the conversation with CL Psychiatry, and there's a lot of questions because we just realised that the psychiatry aspect of pain patients is as integral as every other part of our clinic. All right. Well, I will.
Thank you.
I'll wrap up.
Thanks, Carlos.
Right? Thank you all. We'll finish up.
Thank you. Thanks.